chapter will start with glaucoma. All of you have joined now. We can start. Give me a thumbs up if we can start now. All of you have joined? Yes. Okay, so next chapter we will take on glaucoma. And glaucoma, most of the students think that if the intraocular pressure is raised, then the patient has glaucoma. But that is not the scene. If intraocular pressure is raised, then it is not necessary that patient will have glaucoma, right? So in what situations, in what are the conditions, what are the criteria that needs to be fulfilled so that we can say that the patient has glaucoma. So first write down definition of glaucoma. Write down definition of glaucoma. So glaucoma, remember, it is a disease of optic nerve, right? So it is a group of disorder. It is a group of disorder characterized by chronic progressive optic neuropathy. So it is a optic neuropathy resulting in number 1 point, optic disc changes. Second, irreversible changes, and third, intraocular pressure may or may not be raised. So mere only rise in intraocular pressure is not your glaucoma, right? So three things are there, three criteria are there. There has to be a characteristic optic disc changes, irreversible visual field changes, or intraocular pressure may or may not be raised. Now, what does it mean? So first of all, understand what is visual field changes. We are talking about irreversible visual field changes, right? Now, suppose I am looking in primary gaze position. What is primary gaze position? When I am looking straight, my eyes are not moving here and there to my right or left or superior or inferior. I'm looking straight. Whatever I can visualize superiorly, inferiorly, temporally, and nasally without moving my eyes, this is my normal visual field. Okay. So suppose in glaucoma, what happens? If I'm looking in my primary gaze position, I will feel or I will appreciate some blind spots will be there or some visual field defects will be there in my normal visual field. Suppose I'm looking straight at 2 o'clock. Suppose this is 2 o'clock, this is 12 o'clock position, right? 12 o'clock, 1, 2. Suppose there is a blind spot or visual field defect is there at my 2 o'clock position when I am looking straight, right? So this defect, which is I'm not able to appreciate this area, this is called as visual field defect. Okay. So whatever these visual field defects are there because of glaucoma, these are irreversible. So whatever defect or whatever damage has been done because of glaucoma to the optic nerve, that is irreversible. One is important. So changes in optic nerve due to glaucoma are irreversible. Whatever damage has already been there, it has been done, that is irreversible. Be whatever treatment you start, whatever surgery you do. So what will be the aim of the treatment? If the damage has already started and it is already done, then our aim of the treatment is to reduce the progression of the glaucoma. So whatever damage has already been done, it is irreversible, but we can slow down the progression of glaucoma and we can further prevent the progression of glaucoma in the optic nerve. This much is clear to you? Give me a thumbs up if it is clear. What is visual field? What is normal visual field? Give me a thumbs up. Or should I repeat? Okay. So what is visual field? I am repeating again. If a patient is looking in a straight primary gaze position without moving his eyes, whatever the area I can appreciate without moving my eyes, this is my normal visual field. Okay. Now, what happens in glaucoma is because of raised intraocular pressure, my optic nerve is getting damaged. My optic nerve is getting damaged. So what will I get? I will get visual field defects because of glaucoma. In normal visual field, I will get some defect. What does it mean, defect? There will be some areas in my normal visual field in which I will not be able to appreciate those areas. I will not be able to see those areas. Suppose a local patch at 2 o'clock, at 3 o'clock, some area I cannot appreciate, right? So this is called as visual field defect, and these defects are irreversible. Whatever damage has already been done because of glaucoma, we cannot reverse it. It is already done, right? So if a patient is coming to your OPD, and if you want to rule out whether the patient is having glaucoma or not, right? So 3 criterias are there. First one is optic disc changes, characteristic optic disc changes. Second is irreversible visual field changes and IOP. So every patient has to undergo checking of intraocular pressures should be there. You have to check intraocular pressure in each and every patient. You have to dilate the patient and you examine the retina and you examine the optic disc of the patient. What is the normal cup disc ratio we have discussed yesterday? CD ratio was normal CD ratio. This was optic disc. This was optic cup, right? Yeah, 0.3. Coming back to this image. This was normal, right? So this is cup and this is disc. Hole is the disc. This is my cup. So normal cup disc ratio was, normal CD ratio was 0.3 or less than 0.3, right? So what happens in glaucoma? Because of raised intraocular pressure, normal intraocular pressure range is 11 to 21 millimeters of mercury, right? Now, because of raised intraocular pressure, what happens to optic disc in glaucoma? The cup, this is disc, suppose, and this is my cup. So the cup size increases. Cup size increases, right? Suppose this is cup. This cup size will increase to, this cup disc ratio will be more than 0.5. Means cup will be occupying more than 50% area of the optic disc. So normal is 0.3 or less than 0.3. But in glaucoma, what will happen? The cup to disc ratio will be more than 0.5. Understood? Now this gap we have already discussed. This gap between optic cup and optic disc was called as, it is called as neuroretinal rim, NRR. So automatically this NRR, this is normal. This is normal, right? This is CD ratio 0.3, suppose. This is normal. So this NRR is more, right, in normal eyes. Whereas in glaucoma, if cup size is increased, this NRR will be thinned out, right? So there will be thinning of NRR. Understood? This much is clear. Give me a thumbs up if it is clear. In glaucoma, CD ratio will be more than 0.5 and there will be thinning of neuroretinal rim because cup size is more, right? Right. Then we also discussed yesterday ISNT rule. In normal individual, there is ISNT rule is obeyed, right? So inferior, I told you, inferior neuroretinal rim is broadest in normal individual, followed by superior, then nasal, and then temporal, right? This ISNT rule is not obeyed in glaucoma. In glaucoma, it is not obeyed. Clear? Give me a thumbs up if it is clear. In glaucoma, ISNT rule is not obeyed because cup size increases, right? So one thing is clear. Every patient coming to your OPD, you want to diagnose whether the patient is, or you want to screen the patient for glaucoma. So first thing, you check the intraocular pressure, right? Normal range of intraocular pressure is 11 to 21 millimeters of mercury. Clear? Second thing, you examine the optic disc of the patient. Cup disc ratio has to be more than 0.5. And third criteria is that you check the visual field of the patient, whether there is some visual field defect or not. Understood? So if you want to diagnose the patient, that patient has glaucoma or not, then out of these three criteria, out of these three criteria in the definition which we have discussed, two must fulfill. Two must fulfill if you want to diagnose that the patient has glaucoma. Clear? Now, that means, suppose a patient is having intraocular pressure of 18 millimeters of mercury. Can you say that the patient has a glaucoma? No. Second criteria, you examine the retina, you examine the optic disc, and the optic disc CD ratio is suppose 0.7. Suppose it is 0.7. Can you say that this patient has glaucoma? Yes or no? No. You have to get 3 out of 3. You have to fulfill 2 criteria. So if the patient has visual field defects, VFD is visual field defects also, then out of 3 criteria, 2 criteria are fulfilling. CD ratio is more than 0.5 and there is visual field defects also. Then you can say that the patient has glaucoma, right? Even if intraocular pressure is 18, less than 21, then also patient can have glaucoma. That type of glaucoma is called as normal tension glaucoma. That type of glaucoma is called as normal tension glaucoma. Normal tension means intraocular pressure is normal, but still disc changes are there. Optic disc ratio is more than 0.5 and patient has visual field defects. So out of 3 criteria, if you want to label the patient as glaucoma, then 2 criteria must be fulfilled. Understood? Now, second criteria, suppose a patient is having intraocular pressure of 25 millimeters of mercury, right? First criteria is fulfilled. Second, if the patient is having CD ratio 0.6 and visual field defects are absent, patient has glaucoma or no? Yes. 2 criteria fulfilling, patient will have glaucoma. Clear? So this is briefly I am telling you what is there. Mere increase in intraocular pressure is not glaucoma. So now write down, after definition of glaucoma, what are the investigations which we do in glaucoma? First one is intraocular pressure, IOP measurement. First is intraocular pressure measurement, IOP measurement. The technique of IOP measurement is called as tonometry. The technique of intraocular pressure measurement is called as tonometry. And normal IOP is 11 to 21 millimeters of mercury. Second tonometry, write down. Applanation tonometry. Applanation tonometry. If they ask you which is the gold standard method of measuring the intraocular pressure, and the full Goldman applanation tonometry contains gold, right? So it is the gold standard method for measuring the intraocular pressure. Very, very important question. Is it clear? Okay. So how you measure the intraocular pressure? With the help of Goldman applanation tonometry, how you measure the IOP? So this is how this can you see this small instrument is there in this one. So this is your applanation tonometer, right? This is applanation tonometer is attached to your slit lamp, and when you want to check the intraocular pressure, first you anesthetize the eye with a topical anesthetic eye drop. And this, can you appreciate this biprism is there? This biprism, after staining the cornea with fluorescein dye, you first stain the cornea with fluorescein dye. You touch the tip of this biprism of this applanation tonometer with the tip of the cornea of the patient like this. So tip of the biprism is just touched to the tip of the cornea. And can you appreciate the knob is here, right? So when you touch the biprism, you will see the picture like this. You will see picture like this. These are called as Myers. So these are called as Myers. So what should be the ideal picture? The inner margins of these two Myers should just coincide with each other. So you rotate the knob. You rotate the knob. Till what point you rotate the knob? Suppose these are two Myers like this. These are far apart from each other. The two margins should coincide with each other, right? Now I will rotate the knob, and the point will come when these upper Meyer and the lower Meyer inner margins just coincide with each other. The point where these two Meyers will coincide with each other, that is my reading of intraocular pressure. That is my reading of intraocular pressure. So this is the picture of Goldman applanation tonometer. This is clear how you measure intraocular pressure with Goldman applanation tonometer. Give me a thumbs up if it is clear. So you have to, before measuring IOP, you have to stain the cornea with fluorescein dye. Okay. So they can ask you a direct image-based question also, and they can give you 4 images. So which image will be correct of the Myers? This one, in which the inner margins of both the Myers are just coinciding with each other. That picture will give you exact reading of intraocular pressure, right? So write down. Next investigation, write down. Next investigation is examination of angle of anterior chamber. Examination of angle of anterior chamber. So as you have already heard that there are basically broadly two types of glaucomas are there: primary open angle glaucoma and angle closure glaucoma, right? So when the patient, suppose you have diagnosed that the patient is having raised intraocular pressure and 2 criteria are out of 3 are fulfilling. Now you want to classify whether the patient is having angle closure glaucoma or open angle glaucoma. So we are talking about angles, right? So you have to classify whether the angles are open or whether they are closed. So how you will see whether these angles are open or whether the angles are closed. So how you will check? Write down. Write down examination of angle of AC. It is done to classify. It is done to classify glaucoma as open angle or closed angle. Open angle or closed angle. And how you classify? With the help of technique which is called as gonioscopy. Gonioscopy. So gonioscopy, what we do in gonioscopy, again the patient is made to sit on the slit lamp, and gonioscope is a small lens. It is a small lens. Again, the lens is made to touch the cornea, and through that lens we see the structure inside the angle of the anterior chamber. You remember the angle of anterior chamber? This was the angle of anterior chamber. This space, this one. Between the iris and the periphery of the cornea lies the angle of anterior chamber, which contains trabecular meshwork. So with the help of this gonioscope lens, we will try to see the structures which are present in the angle of the anterior chamber. Based on the clarity of the structure, whether all the structures can be seen or not in the angle, we can classify that the angle is closed or angle is open. If angle is closed, then we say that the patient has angle closure glaucoma. If angle is open, then we say that patient has primary open angle glaucoma. Is it clear? Give me a thumbs up if it is clear. Why stain? Someone has asked me why we are staining the cornea prior to doing applanation tonometry. In order to see the Myers. See, whenever we are touching the epithelium of the cornea, as I told you, we have to stain the cornea with fluorescein dye. Only and only then we can see the Myers. If you are not staining and you are touching the cornea, you will not see any color or you will not see any Myers. So we have to see the structures, and then you will classify that the angles is closed or whether angle is open, right? So write down what structures are seen in angle. In normally, what angles are seen, what structures are present in angle? Write down structures in angle of anterior chamber. From posterior to anterior. Posterior means towards iris, and anterior means we are going towards cornea. So posterior most structure which we see is ciliary body band. Ciliary body band. Then comes your scleral spur. Then comes your trabecular meshwork. And then comes your Schwalbe's line. Schwalbe's line. Right? So these are the structures which are normally seen in the angle of the anterior chamber. If these structures are not seen in the angle of anterior chamber, then we will say that the angle is closed. Right? If these are present, we can say that the angles are open. Okay? Right. So now we will take on primary open angle glaucoma. Write down. Primary open angle glaucoma. It is also known as chronic simple glaucoma. It is also known as chronic simple glaucoma. Chronic means it is not an acute glaucoma. It develops usually after age of 40 years, and it usually takes 30 to 40 years to develop. That is why it is called as chronic simple glaucoma. Okay. Now you will tell me, if in primary open angle glaucoma, your angles is open, right? In primary open angle glaucoma, angles are open. Now you will tell me why intraocular pressure is raised if angles are open. So there is a pathway for aqueous humor outflow is there, right? Because the angles are open, trabecular meshwork is open. Then why the intraocular pressure is raised in primary open angle glaucoma? Obstruction is there? No. If angles are open, trabecular meshwork is there, open, then why the intraocular pressure is raised? Production increases? No. Production is from ciliary body, it is not increase in POAG. Now write down mechanism of primary open angle glaucoma. Here lies the answer. There is inherent defect or abnormality of trabecular meshwork. TM is trabecular meshwork. Because of this inherent abnormality, is obstructed, which leads to raise in intraocular pressure. Right? Now talking about etiology. First, it occurs in old age, more than 40 years of age. Family history is present. Family history is present. Third, which genes are associated? Important question. Which genes are associated with primary open angle glaucoma? Important one is, write down optineurin gene. Optineurin, IN. Second important gene is MYOC. Question has been asked on MYOC and optineurin also. Fourth association of primary open angle glaucoma is myopia. It is associated with myopia, diabetes, and hypertension. So you have to remember, all of them are very, very important. Family history is important. If it runs in your family, right? If your parents are having history of primary open angle glaucoma, 30 to 40% chances are there that it will pass on to next generation. So screening should be done in those families who have history of primary open angle glaucoma, right? Myopia has association with primary open angle glaucoma. Write down symptoms. Because intraocular pressure is raised, patient will complain to you with headache. Second complaint, patient will complain to you with frequent changes in presbyopic spectacles. Coming to signs, intraocular pressure will be more than 21 millimeters. IOP is more than 21. Talking about optic disc changes. What are the changes in optic disc in primary open angle glaucoma? What are the changes you see in optic discs? See the picture of glaucoma. Can you appreciate the cup size? is more than normal CD ratio, right? So this is around 0.7 cupping, right? So when cup size increases, automatically the NRR will be thinned out. So there will be thinning of NRR, right? So in primary open-angle glaucoma, CD ratio must be more than 0.5. CD ratio must be more than 0.5. Write down. In optic disc changes, write down. CD ratio is more than 0.5. And when CD ratio is more than 0.5, there will be loss of neuroretinal rim. There will be loss and thinning of neuroretinal rim, right? Next important sign in optic disc changes, write down. You will see laminar dot sign. Laminar dot sign. So you will see dot-like fenestrations on optic disc. Suppose this is your optic disc and this is your optic cup. You will see fine dot-like fenestrations on the optic disc. This is called as laminar dot sign, characteristic feature of primary open-angle glaucoma. Third important sign is called as Beonating sign. What is Beonating sign? Going back to the diagram again. Suppose this is your optic disc, optic cup, and I told you the central retinal vessels, they emerge from the optic cup, right? So this is how normally the vessels emerge from the optic cup. What happens in primary open angle glaucoma in Beonating sign? Appreciate this one. See, can you see this angle? This angle, this vessel, before exiting the optic disc margin, this is your optic disc margin, right? So before exiting this margin, or before coming out of this optic disc, there is double angulation. Can you appreciate the double angulation of vessel is there? This double angulation of vessel is called as Beonating sign. Write down definition. It is double angulation of a blood vessel. So this picture is seen in primary open angle glaucoma. Double angulation of a blood vessel is called as Beonating sign. Give me a thumbs up if it is clear. These are the changes which we see in POAG in optic disc. CD ratio has to be more than 0.5. NRR will be thinned out. Laminar dot sign can be there. And there can be Beonating sign. Double angulation of a blood vessel. Right? Clear? Next important sign, write down. In optic disc only, you will see peripapillary atrophy. Peripapillary atrophy. What is peripapillary? This is optic disc. This is optic cup. So here in glaucoma, peripapilla means optic disc. And peri means surrounding optic disc. So surrounding the optic disc, you will see some atrophic changes like this. Draw this diagram. So there are two zones of peripapillary atrophy. This outer zone is called as alpha zone, and this inner zone is called as beta zone atrophy. Alpha for outer, right? Alpha zone is outer and beta is inner. So alpha zone is specific to glaucoma. This type of atrophy, alpha zone atrophy, is specifically seen in glaucoma, whereas this beta zone atrophy can be seen in myopia also, right? In myopia also, this can be seen. So someone has asked single or multiple. Usually single vessel is seen in Beonating sign. In the inferior quadrant, double angulation of vessels is seen. So this is a peripapillary atrophy, two zones, alpha zone and beta zone. Alpha for outer. So alpha is outer, beta is inner zone. Alpha is specifically seen in glaucoma, whereas beta zone atrophy can also be seen in myopia. Now write down visual fields. Visual field. I told you the normal visual field when you are looking at primary gaze position. When I am looking alpha zone only in POAG or open also. POAG is open, right? POAG full form is primary open angle glaucoma. So alpha zone is seen in primary open angle glaucoma, yes. So I told you about visual field. Normally when I was looking in primary gaze position, all the area which I can see, that is your normal visual field, right? And yesterday also I told you about blind spot, right? Optic disc is also called as blind spot of Marriott, right? Remember? There was no vision image formation at the blind spot at our optic disc. Why? Because photoreceptors, rods and cones were absent on the optic disc, right? You remember the blind spot of Marriott. Optic disc is called as blind spot of Marriott, right? So draw this diagram. Normal visual field. What is the extent of normal visual field in normal individual? So this is our blind spot here. This is our optic disc, suppose. This is your blind spot. So what normally, how much area you can see? This is your normal visual field. This is temporal area. This is nasal side. This is superior and this is inferior, right? So can you tell me in which quadrant you can see maximum without moving your eyes when you are looking straight? See, superiorly there is, this bone is coming in my view. Nasally, my nasal bridge is coming, right? Nasally, nasal bridge is coming. Temporally, yes. Temporally, there is no hindrance coming in my way. Inferiorly also there is, this bone is coming. So maximum visual field is normally in temporal quadrant, right? So write down the degrees. You have to remember in temporal quadrant, you can see 100 degrees. In superiorly, you can see 55 degrees. Nasally, you can see 60 degrees. And inferiorly, it is 70 degrees. So these degree can be up and down, but you have to remember that maximum visual field is there in temporal quadrant and minimum is in superior quadrant. Minimum is there in superior quadrant. Clear? Okay, now coming back to this image again. See, this was the normal anatomical picture. What is the normal route of aqueous humor outflow? From where the aqueous humor comes, what is the site of production of aqueous humor? Please tell me in the chat box, what is the normal site of aqueous humor production? CB, yes, ciliary body, right? So this is your ciliary body. This is your ciliary body, right? And these are your ciliary processes. So from the non-pigmented epithelium of ciliary processes, aqueous humor is coming into this area, right? It is released into this area. So what is this area? This is which area? Aqueous humor is released in which area? This area, the gap between iris and this lens, anterior capsule of lens. This part. This part is, what is the name of this area? Behind the iris, PC, right? So after releasing from the ciliary body, ciliary processes, aqueous humor is released into PC. From PC via the pupillary margin, this red arrow, via the pupillary margin, it enters into anterior chamber, right? From anterior chamber, it will go into both the direction, both the peripheries. And in the periphery, you will see what is present? Angle of anterior chamber, right? So in the periphery, it will go in the anterior chamber, both the periphery, it will go in the angle of anterior chamber. And which structure is present in angle of anterior chamber? Write down. Short form. Which structure is present in the angle of anterior chamber? Which is responsible? Trabecular meshwork, right? Trabecular meshwork is the main structure through which aqueous humor will leave the eyeball, right? Aqueous humor will leave through the trabecular meshwork. So this is a trabecular meshwork, which is a sieve tube-like structure. It contains several pores are there in trabecular meshwork, right? So through these pores, your aqueous humor will exit the eyeball and it will go to episcleral vein, which will further drain into cavernous sinus, right? So no need to go into detail. Just remember that in the angle, the maximum exit or the maximum outflow of the aqueous humor occurs through trabecular meshwork. And what is the other outflow? 90% of the trabecular, 90% of aqueous humor goes out through the eyeball through the trabecular meshwork. But some part of aqueous humor also goes through uveoscleral outflow. This is uveoscleral outflow. This is less important, but you should remember that there are two exit pathways. The 90% is trabecular meshwork and 10 to 20% the exit is through uveoscleral outflow. Uveoscleral outflow means the outflow between your ciliary body and your sclera. Uveoscleral means the exit occurs between sclera and ciliary body. Episcleral vein connects this sclem canal, this trabecular meshwork, sclem canal. They are connected via episcleral vein, and this vein drains into your cavernous sinus. Right? So just remember, don't remember episcleral vein also. Just remember trabecular meshwork is there and uveoscleral route is there. Uveoscleral route is responsible for 10 to 20% of aqueous humor outflow, and the maximum outflow occurs through trabecular meshwork, right? Uveoscleral route is present between sclera and ciliary body. Clear? Now coming back to the treatment part. If we talk about the primary open angle glaucoma, if we start the patient on medical drugs, can you tell me what should be the aim of the medical treatment? How we can decrease the intraocular pressure? So we can decrease intraocular pressure by two methods. Either we give a drug which act on the trabecular meshwork so that the outflow of the aqueous humor increases, right? So we have to, number one, either we increase the aqueous humor outflow, then automatically the intraocular pressure can decrease, right? Second, if we decrease the production of aqueous humor from the ciliary body, then also we can decrease the intraocular pressure, right? So there are basically two broad methods. First, either we decrease the production of aqueous humor from ciliary body, or second, we increase the aqueous humor outflow from the trabecular meshwork. So write down treatment. Write down the treatment of primary open angle glaucoma. So first we will discuss medical treatment. Medical treatment of glaucoma in primary open angle glaucoma is the mainstay. Like surgery was mainstay in cataract surgery, right? Medical treatment was not there in cataract. In primary open angle glaucoma, the mainstay is medical treatment. So first category of drug in primary open angle glaucoma is, write down, PGF2 alpha analogs. These are called as prostaglandins analog. Prostaglandins analogs. If they ask you drug of choice of primary open angle glaucoma, then answer will be PG analogs. Answer will be PG analog. Example write down of PG analog. All the prost are PG analog. So example is latanoprost, bimatoprost, bimatoprost, and travoprost. So the drugs which are ending with prost, these are prostaglandin analogs, and these are the drug of choice for primary open angle glaucoma. Very, very important. Now you have to remember the mode of action also. What is the mode of action of PG analogs? They increases the uveoscleral outflow. They increases the uveoscleral outflow of aqueous humor. USO is uveoscleral outflow. Talking about the dosing schedule of PG analog drugs, they are given in OD doses before sleep, 9 p.m. Talking about what are the ocular side effects of these drugs, they causes hypertrichosis. What is hypertrichosis? Any idea? What is hypertrichosis is? Hair. No, it's not about hair. These are eyelash. Specifically, eyelash growth increases. Hypertrichosis. Second, they causes heterochromia iridis. Hetero means different. Chromia means color. So different color of the iris. Important question. They causes heterochromia iridis. Third, they causes uveitis. Fourth, cause herpetic keratitis. They causes reactivation of herpetic keratitis. So these four ocular side effects are important. Very, very important. Out of all the four, hypertrichosis and heterochromia are very, very important. Right? Next class of drug which is used is, write down, second, beta blocker. The name most commonly used beta blocker in ophthalmology is timolol. Timolol. Mode of action, write down. They decreases aqueous secretion. Talking about dosing, it is given in BD doses, morning and evening doses. Coming to of timolol or beta blockers, they causes allergic blepharoconjunctivitis. They causes allergic blepharoconjunctivitis. Second one is important for your exam point of view. Duct obstruction. Lacrimal duct obstruction. Where is nasolacrimal duct? This is, see, there are two punctas are there. If you see from where your tear flow, right? Upper puncta, small hole is there, and this is lower puncta. These puncta, they unite and form common canaliculus which open in nasolacrimal duct, right? So these timolol and beta blockers, they causes nasolacrimal duct obstruction, right? NLD is nasolacrimal duct obstruction. Third category of drug, write down, alpha agonist. Alpha agonist. Examples, write down for alpha agonist: apraclonidine. Apraclonidine, and B for brimonidine. Brimonidine. This apraclonidine mode of action, write down. It decreases aqueous secretion, plus it increases trabecular outflow. TO is trabecular outflow. So apraclonidine decreases aqueous secretion, and it also increases your trabecular outflow of the aqueous humor. Whereas brimonidine decreases aqueous secretion only. It decreases aqueous secretion. Coming to ocular side effects. A for apraclonidine. It causes, number one, mydriasis. It causes mydriasis, dilated pupil, right? And second, it causes eyelid retraction. Retraction. B for brimonidine. Brimonidine is depression. And second side effect of brimonidine is the one through which all of you are going right now: drowsiness. So, and drowsiness. Clear? Both of these are very, very important. Depression, drowsiness, eyelid retraction, mydriasis. Very, very important. Next class of drug, write down. One more important point, write down in brimonidine only. This brimonidine is, CI is contraindicated. So brimonidine is contraindicated in children's less than 2 years of age. Why it is contraindicated? Because it crosses blood-brain barrier. It crosses blood-brain barrier. That is why it is contraindicated in children less than 2 years of age. Next class of drug, write down after these: alpha agonist, carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. Example, write down. Acetazolamide, brinzolamide, dorzolamide. Out of these three, the acetazolamide is not given. It is not given topically. It is not given in eye drop form. It is given orally. Tablets are given. Whereas these brinzolamide and dorzolamide, these two drugs are contraindicated. CI is contraindicated in patients who have sulfa allergy. Important question. Brinzolamide and dorzolamide are contraindicated in patients who have sulfa allergy. Okay. Write down mode of action. It decreases aqueous secretion. It decreases aqueous secretion. So medical treatment is clear. Shall we move on now? Give me a thumbs up if you are done with medical treatment. So in glaucoma, in primary open-angle glaucoma, you cannot afford to miss medical management. It is very, very important for your exam. All the drugs, name, classification, ocular side effects, mode of action, you have to remember. Right? So after medical management, suppose a patient had the intraocular pressure of 30 millimeter of mercury, and patient is diagnosed as primary open-angle glaucoma, and I started the patient on medical treatment. Clear? So we can start with one drug depending on the pressure. We can give combination of two drugs also or three drugs also. Now suppose the patient, because these drugs are for lifelong, patient has to put these eye drops for lifelong in order that the IOP is under control. So many patients are not very compliant with the medication, right? So in such patients, we can go for surgery, right? And another indication for surgery is if the intraocular pressure is not under control, even after maximum medical therapy, IOP is not under control, then also we can go for surgical treatment, right? So now write down next topic. After medical management, we will discuss surgical treatment. Surgical treatment for primary open-angle glaucoma. So first surgical treatment, write down. It is called as trabeculectomy. You just need to remember the name of this surgery. What we do in trabeculectomy, write down. We create a fistula connection, right? A bypass. So we to allow aqueous humor outflow, from anterior chamber AC, to subtenous space, creating a bleb. Suppose this is our globe, this is our cornea, right? This is our eyeball. So the innermost layer, this one is your sclera. Above the sclera, which layer is present? Your above the capsule is present. Tenons capsule. Above this Tenon's capsule, there is a fine layer of conjunctiva. This layer. This is your conjunctiva. So from the anterior chamber, suppose this is anterior chamber. From the anterior chamber, we will create a fistula which will allow aqueous humor outflow into this subtenon space. Subtenon means below the Tenon's capsule and above the sclera. This one. Above the sclera and below the Tenon's capsule, there is a space which is called as subtenon's space, in which the aqueous humor will be collected from the anterior chamber, and it will create a bleb. A raised bleb will be there, through which aqueous humor will come out, right? So just need to remember the name of the surgery, right? What is the surgical option? The first surgical option is trabeculectomy, right? Next surgical option is, even if after doing trabeculectomy, the patient is not under control, glaucoma is not under control, intraocular pressure is not under control, even after doing trabeculectomy surgery, then the last option we have is we can implant some devices which are called as glaucoma drainage devices. Glaucoma drainage devices. They are also called as tube implants. They are also called as tube implants. So basically what we do in these tube implants, what we do, look at me, what we do in glaucoma drainage devices, this is the last option what we have to control the intraocular pressure. So when you look into the down gaze position, these are devices which have a round body connected with a silicon tube. This silicon tube is connected. Now this silicon tube, this plate, this round plate, it is implanted in my superior part of the conjunctiva. I'll cut the conjunctiva, I'll implant this ring or the tube over this superior part of the conjunctiva, and this silicon tube will directly enter into my anterior chamber. From this anterior chamber, this tube will suck the aqueous humor, and the aqueous humor will be collected in my this ring, right? So this is the basic idea which I want to give about the glaucoma drainage devices. From your exam point of view, the mechanism is not important. You just need to remember the name of the glaucoma drainage devices, right? So write down the name of the glaucoma drainage devices. The most important one is Ahmed glaucoma valve. Ahmed glaucoma valve. Second example is Molteno device. Molteno device. And the third name of the glaucoma drainage device is, this is asked in NEET PG exam also, Express Mini Shunt. Express Mini Shunt, which is made up of which material? So these are the instruments which are implanted in the anterior chamber, through which access of the aqueous humor sucks out of the eye. So IOP comes in the normal range. So this is the last option after trabeculectomy. So if they ask you which is the mainstay of treatment in primary open-angle glaucoma, then your answer has to be, it is medical management. It is medical management. Clear? Are you done with POAG? Give me a thumbs up. Shall we move forward now to the next topic? Give me a thumbs up. Okay. Now coming back to next topic, which is angle closure glaucoma. Angle closure glaucoma. So as we have discussed about POAG, the other name of POG was chronic simple glaucoma, right? So it is a chronic glaucoma. It takes time. It takes time. And the IOP is usually in the range of 24, 25 to 30 millimeters of mercury only. Okay. In primary open glaucoma, the range of IOP is usually in the mid 20s and 30s. Whereas, on the contrary, in the angle closure glaucoma, because angles are closed, right? Because angles are closed, trabecular meshwork is closed. So there is sudden rise of intraocular pressure in angle closure glaucoma. It is an acute condition. It is an acute condition. But because it is an acute condition, patient will have severe headache as compared to POAG. Patient will have severe headache in angle closure glaucoma, right? So try to understand what is the pathology behind the angle closure glaucoma in this diagram. Now suppose this is the first stage. This is the first stage. The first stage is stage of pupillary block. First stage is stage of pupillary block. Can you see this black spot is there? Black spot. This one. So there is blockage of the pupil at this site. Why there is blockage at this site? Because in angle closure glaucoma, intraocular pressure is so much high, about 50 to 60. It can go up to 100 millimeters of mercury also. Because in such high intraocular pressure, there is paralysis of sphincter pupillae muscle. There is paralysis of which iris muscle? Sphincter pupillae muscle. Because of this paralysis, what will happen? Pupil will be mid-dilated. Pupil will be mid-dilated and it will be mid-dilated and vertically oval. Mid-dilated, vertically oval, right? Pupil will not constrict because of paralysis of sphincter pupillae muscle. Why there is paralysis of this muscle? Because IOP is very, very high in angle closure glaucoma. IOP is around 60 to 70 millimeters of mercury. That is why there is paralysis of iris muscle. And because of paralysis of sphincter pupillae, what was the function of sphincter pupillae? It causes meiosis, right? It causes constriction of pupil. Now, because there is paralysis, meiosis will not be possible, right? So pupil will be mid-dilated. Now, when the pupil is mid-dilated and there is paralysis of muscle, there will be attachment of the iris from the lens capsule. This is my cornea. This is my iris. Behind the iris, what is present? Lens, like this. This is your lens, right? So because of paralysis, mid-dilated pupil is there. There will be attachment of iris from the anterior capsule of the lens. Which capsule of lens? Anterior or posterior? This is anterior capsule of lens, right? This is anterior capsule, right? This is posterior capsule. So attachment will be between iris and anterior capsule of lens. This much is clear. Give me a thumbs up if this much is clear or not. Why there is paralysis of muscle? Why the pupil is mid-dilated, not reacting to light? Why it is fixed? And why there is adhesion between iris and anterior capsule of lens? This is clear. Give me a thumbs up if this much is clear. Okay, I'll repeat. See, acute angle closure glaucoma or angle closure glaucoma is different from POAG. Why? It is different because angles are closed in angle closure. Trabecular meshwork is blocked. Aqueous humor, there is no pathway for aqueous humor to exit, right? So IOP will be rise. It will be on very higher side, more than 50 millimeters of mercury, up to 100, right? So in such high pressures, there will be paralysis of which muscle? Sphincter pupillae muscle. What is the function of sphincter pupillae? It causes constriction of pupil. If that muscle is gone, there will be no constriction of pupil. Pupil will be in which state? It will be in dilated state. Vertically oval. If you throw the torchlight on this pupil, pupil will not constrict. It will be fixed, non-reacting. Now, because it is fixed and non-reacting, there will be adhesion of this pupil margin or the iris with the iris and the anterior capsule of lens. So there will be adhesion between iris and anterior capsule of the lens if it is mid-dilated, right? Now, because there is adhesion and intraocular pressure is raised, This is ciliary body. From this side, aqueous humor is continuously releasing. And as I told you, this aqueous humor will, from the posterior chamber, from ciliary body, it goes to posterior chamber. From posterior chamber, it goes via pupil into the anterior chamber normally, right? But in this case, pupil is blocked because there is adhesion between iris and your lens. So because pupil is blocked, obviously the aqueous humor, there is no pathway or there is no route for aqueous humor from the PC. It cannot move into anterior chamber. Clear? So when there is no movement of aqueous humor from the posterior chamber to anterior chamber, what will happen? Pressure will build up in the posterior chamber. Pressure will build up where? In the posterior chamber, right? So now comes your second stage. When there is pressure is building up of the aqueous humor in the posterior chamber, this aqueous humor will push the iris forward. It will push the iris forward towards the cornea because pressure is building up in the posterior chamber, because aqueous humor is continuously releasing from the ciliary body, right? And there is obstruction. So the aqueous humor will push the iris forward towards the cornea. Clear? Now, because this, can you see the shape of the iris has changed now? It has assumed a convex shape, right? So this convex shape of iris is called as, second stage is called as iris bombi. This convex shape of the iris is called as iris bombi. Clear? This much is clear? Give me a thumbs up. Till iris bombi is clear, the pressure is building up in PC and aqueous humor is pushing the iris forward towards the cornea, right? Now continuously again the pressure is building up, right? Now there will be a stage when this iris, because of pressure building up, this iris will come in contact, it will touch the cornea. There will be a stage when this iris, convex iris, will touch the periphery of the cornea here. There will be contact. This is your stage 3. Can you appreciate the contact? There is adhesion between iris and your endothelium of the cornea. Understood? This adhesion is called as PAS. This adhesion of the iris with the cornea, periphery of the cornea, is called as peripheral anterior synechia. Synechia means adhesion. Why it is anterior? Because it is adhesion between iris and cornea is anterior structure, right? Cornea is anterior structure. So this adhesion is called as irido-trabeculo-corneal contact. Irido-trabeculo-corneal contact. Why it is trabeculo? Because in between iris and cornea, which structure is present in angle? Trabecular meshwork, right? So when iris is pushing towards the cornea, obviously your trabecular meshwork will also get in contact. So there is adhesion of iris, trabecular meshwork, and the periphery of the cornea. This contact is called as PAS, peripheral anterior synechia. Why it is called as anterior synechia? Because adhesion is between iris and cornea. If the adhesion is present between iris and your lens, that adhesion is called as posterior synechia. Why posterior? Because the adhesion between iris and lens. Lens is posterior, right? Cornea is anterior. So adhesion between iris and lens is posterior synechia. Adhesion between iris and cornea is anterior synechia. This much is clear. Pathology between angle closure glaucoma pathology is clear. Give me a thumbs up if it is clear. Good. Write down now. Next heading, write down angle closure glaucoma. Next heading, write down primary angle closure glaucoma. Mechanism we have discussed. Write down this risk factors. What are the risk factors for primary angle closure glaucoma? So hypermetropia. It is associated with hypermetropia. As I told you, which refractive error was associated with primary open angle glaucoma? In risk factors, POAG was associated with myopia, right? In this angle closure glaucoma, it is associated with hypermetropia, right? And also, I told you during when I was discussing axial length, right? Normal axial length is 24 millimeters. The normal globe is 24 millimeter long, right? So if the eyeball is longer, if it is a bigger size, if it is more than 24 millimeter, I will become myopic or hypermetropic. If the eyeball is bigger in size, bigger eyeball, short name. Bigger eyeball, short name. Short name is myopia. So if axial length is more than 24 millimeter, short name is myopia. If the eyeball is small, less than 24 millimeters, big name, hypermetropia. Eyeball is less than 24, short, right? So it is hypermetropia. So here, primary angle closure glaucoma is associated with hypermetropia. Now, can you tell me, in hypermetropia, anterior chamber depth will be more or it will be shallow? AC will be deep or shallow? Hypermetropia, small eyeball. Everything is small in hypermetropia. So anterior chamber will be deep or shallow? Think. Axial length is short. Everything is short. So AC will be shallow. Whereas in myopia, AC will be deep because axial length is more. Right? So space will be more. AC will become deep. So shallow AC is seen in hypermetropia, and shallow ACs are more prone to develop angle closure glaucoma. Okay. So write down next risk factor after hypermetropia. Females are more prone to develop angle closure glaucoma. Third risk factor, shallow anterior chamber. Shallow anterior chamber. Now, next important point. So, what is the state of pupil in angle closure glaucoma? Pupil is constricted or pupil is mid-dilated? Pupil is constricted here or it is mid-dilated fixed? Mid-dilated, right? So, if I want to treat this patient, should I dilate the pupil further with the drug or should I try to constrict the pupil, bring it back to the normal position? Should I further dilate or should I constrict the pupil? I should constrict the pupil and should not dilate. If I try to dilate the patient, that condition may worsen further. Condition may worsen further. So I will try to constrict the pupil, right? Which is the drug which we use to constrict the pupil? We have discussed it. The drug used to constrict the pupil. Meiosis. Atropine is used to dilate the pupil. Mydriasis. What was the mnemonic for mydriasis? Big oats. And for meiosis, it was high cops. Right? High cops. So P for pilocarpine, right? So pilocarpine is used to constrict the pupil, right? So suppose the patient is having angle closure glaucoma, acute attack, and the pupil is mid-dilated. What advice should I give this patient? What advice should I give? They will ask you in the exam. In the history, they will give you, write down. This angle closure glaucoma, write down, it is precipitated. It gets precipitated by dim light. It gets precipitated by mydriasis. And it gets precipitated. So these patients are advised not to visit cinema halls. Can you tell me why? What is the logic behind this line? They are advised not to visit cinema hall because in cinema hall there is dark. In the dark, what happens? There is relative mydriasis. And if there is relative mydriasis, this condition will worsen further. Right? Yes. Right. Coming back to symptoms of this condition, patient will have severe pain. Patient will have severe pain associated with vomiting. Patient will have severe pain and it is associated with vomiting. That much severe pain is there. Patient will have redness in the eye. There will be sudden loss of vision. LOV is sudden loss of vision. Why there is sudden loss of vision? Write down. Because of corneal edema. Corneal edema. Why there is corneal edema? Due to rise in intraocular pressure. Due to sudden rise in intraocular pressure, cornea becomes hazy. Cornea becomes edematous. That is why there is sudden loss of vision. Clear? Patient will also complain to you with complaints of colored halos. Patient will complain to you with colored halos. The reason of colored halos, write down. It is because of corneal epithelial edema. Corneal epithelial edema. Why there is edema, corneal edema? Reason is clear. Because of sudden rise in intraocular pressure, cornea will become hazy. The normal transparency of the cornea is lost. Cornea becomes slight hazy. That is why a patient have diminution of vision. Okay. Next, write down. Patient will have pupil. Write down. What is the state of pupil? Pupil will be vertically oval. Pupil will be vertically oval. It will be mid-dilated. Vertically oval, mid-dilated, fixed. Vertically oval means it is non-reactive to light. It is non-reactive to torchlight. Okay. Now, mid-dilated. Right, have to remember the name of the muscle. It is due to sphincter pupillae paralysis. And why there is sphincter pupillae paralysis? Due to, write down, sphincter pupillae paralysis due to rise in intraocular pressure. Due to rise in intraocular pressure. Clear? So clinical features are clear. Give me a thumbs up if it is clear. Clinical features. Why pupil is mid-dilated, non-reactive to light. Okay. Now you will tell me, if I plan to treat this patient, what should be the aim of the treatment? See, this is an acute condition, right? So you have to bring down the intraocular pressure suddenly. You cannot give him tablets because already the patient is vomiting, right? He's already doing vomiting. So you cannot give tablets, oral tablets. You cannot put eye drops and try to bring down the IOP with the help of timolol or PG analogs, right? So how you will decrease the pressure? IV route, yes. You will not plan the surgery immediately. So yes, IV mannitol is one option, So basically the aim is to bring down the IOP suddenly, right? Fast. So how you bring down the intraocular pressure suddenly? Write down. So there are two conditions. If the patient is under the attack of acute angle closure glaucoma, if they, in the exam, if they give you condition acute angle closure glaucoma, that means it is an acute condition, right? So you have to give IV mannitol to bring down the intraocular pressure suddenly. But if they give you condition which is angle closure glaucoma, that means it is not an acute condition. Angles are closed, pressures are high, right? But it is not so much high that it is acute condition, right? So in that scenario, if they have given angle closure glaucoma, then the drug of choice is, write down, treatment. First option, write down. Drug of choice, if they ask you, then the drug of choice is pilocarpine. You will try to constrict the pupil. Pilocarpine. Drug of choice for primary angle closure glaucoma. PACG is primary angle closure glaucoma. What is the mode of action of pilocarpine? It causes tightening of iris. Tightening of iris. It tries to pull the iris from the periphery and bring down to normal position. So it causes tightening of iris and helps to open the angle, right? Now, second drug of choice, write down. If they ask you drug of choice for acute cases, then the drug of choice is IV mannitol, or it is acetazolamide. Acetazolamide, oral tablets are given orally, right? Understood? Now, if in exam, they ask you drug of choice for acute cases of angle closure glaucoma, if they ask you acute angle closure glaucoma, drug of choice, and if only IV mannitol is present in out of 4 options, answer will be IV mannitol. If both IV mannitol and acetazolamide are present in the question, then answer will be IV mannitol. Okay? Understood? So IV mannitol is our first priority, and second option is acetazolamide. So in exam, you have to look whether both options are given or not. If both of them are given, mannitol as well as acetazolamide, then the best answer is mannitol. Okay? Give me a thumbs up if it is clear. Give me a thumbs up if it is clear. IV mannitol, acetazolamide, both are correct answers, but the best one is mannitol. Okay? Yes. So after starting with IV mannitol, after starting the patient with mannitol or acetazolamide, suppose IOP, I want to bring down further IOP after starting the treatment medically. What else I can do? Suppose this is a iris Bombay condition, right? Iris is convex shape. Now with the help of laser, suppose I make a hole in this iris. Suppose I make a hole in this iris. What will happen? The aqueous humor in PC here, the aqueous humor in the PC will get an alternate pathway to pass through this hole into the anterior chamber. Then automatically the intraocular pressure will bring down to normal. Understood? This making a hole process in the iris is called as laser iridotomy. It is called as laser iridotomy. This is clear? How can I bring the intraocular pressure down? If I, with the help of laser, I'll make a hole in the iris. So automatically the aqueous humor which is accumulated in the PC, it will get an alternate route to pass from PC to AC, and IOP will come to lower sides. Clear or not? Give me a thumbs up. Laser iridotomy. Laser iridotomy. Clear or not? I'm making a hole in the iris with the help of laser, and the aqueous humor which is obstructed behind the iris, it will come from the PC towards the AC through this hole, which I have created through the laser. Okay, now write down next treatment option. Next treatment option, write down laser IRE.me. Laser IRE.me. So what I am doing in laser IRE.me? And which laser is used? Again, ND-YAG laser. This laser was also used in after cataract, posterior capsular opacification, right? So same laser is used. If they ask you the treatment of choice, if they ask you treatment of choice for acute angle closure glaucoma, then answer will be laser IRE.me. Answer will be, because laser is a treatment, it is not a drug. If they ask you in exam drug of choice, then drug of choice can be IV mannitol, acetazolamide, pilocarpine, right? If they ask you treatment of choice for acute angle closure glaucoma, then answer will be laser IRE.me. Clear or not? Any confusion? If they ask you, see, there are three scenarios. I'll discuss again. Three scenarios are there. If they ask you the drug of choice for primary angle closure glaucoma, it is not an acute condition. Primary angle closure means angles are closed, but the patient doesn't have so much of pain. It is not an acute condition. So if they ask you drug of choice for primary angle closure glaucoma, answer will be pilocarpine eye drops, right? If they ask you acute angle closure glaucoma, acute condition, drug of choice, then number one answer will be mannitol. Second number choice will be acetazolamide tablets, right? And if they in exam they ask you treatment of choice for acute angle closure glaucoma or angle closure glaucoma, treatment of choice, answer will be laser IRE.me. Laser IRE.me will be your treatment of choice. Give me a thumbs up if any doubt is there. So there's difference between treatment of choice and drug of choice. Treatment is laser IRE.me, drug is pilocarpine, mannitol, and acetazolamide. Clear? Good. So this is all about today. Tomorrow we will continue again. YAG laser is for sir. YAG laser, yes. ND-YAG laser is we were doing capsulotomy also, and we are doing IRE.me also. ND-YAG laser. ND means neodymium. ND-YAG. ND means neodymium. Neodymium YAG laser is used. Clear? So this is all about today. We'll try to finish tomorrow.